deep vein thrombosis, DVT, occurs when a combination of venous stasis, endothelial injury, and hypercoagulability known as Virchow's triad. This process typically begins in the hypoxic environment of venous valve pockets, where activated endothelial cells and leukocytes release tissue factor, triggering the coagulation cascade. This leads to the formation of a red clot, dominated by a fibrin mesh and trapped erythrocytes. If the clot propagates, it risks dislodging to become a pulmonary embolism, or it may trigger a chronic inflammatory response that scars venous valves, leading to post-thrombotic syndrome. The diagnostic gold standard for DVT is the compression duplex ultrasound. Laboratory investigations begin with the D-dimer assay, a highly sensitive test used to rule out the condition by detecting fibrin degradation products. Baseline blood tests and coagulation screen are essential to establish baseline clotting times. For patients with unprovoked or recurrent clots, a thrombophilia screen is conducted to check for genetic or acquired issues such as factor V Leiden. Finally, basic screening for underlying malignancy may be performed as cancer is a known driver of hypercoagulability. The Wells score for DVT is a point-based system used to guide diagnostic testing based on clinical features like active cancer, immobilization, and localized swelling. A patient is awarded points for symptoms such as calf swelling over 3 cm or a previous DVT, while 2 points are subtracted if an alternative diagnosis is equally likely. A total score of 2 or higher indicates a DVT is likely, while a score of 1 or less suggests it is unlikely. The Wells score for PE follows a similar logic but focuses on different clinical markers like tachycardia to determine if a pulmonary embolism is likely enough to warrant a CT scan. The primary goal of management is to prevent clot propagation and pulmonary embolism. Treatment typically begins with anticoagulation therapy, such as low molecular weight heparin or direct oral anticoagulants like rivaroxaban, usually for a minimum of 3 to 6 months. In cases of massive proximal DVT where there is a risk of limb-threatening ischemia, thrombolysis or surgical thrombectomy may be used to actively dissolve or remove the clot. Long-term management often includes the use of compression stockings to reduce venous pressure and minimize the risk of post-thrombotic syndrome.